Welcome to this episode of Conceptual Anesthesia. And today we'll be discussing about a very important subset of infections, which is management of invasive mucormycosis. And slowly and steadily, the number of patients that you see in the critical care units of invasive mucormycosis are increasing. The patients who are having risk factors like uncontrolled diabetes, patients of hematopoietic stem cell transplants, solid organ transplants, patients post chemotherapy, patients receiving high dose steroids because of some immunological illness or rheumatological illness. They're all slowly and slowly increasing if you work in a critical care setting. So that is why, because the risk factors are increasing, the patients who are and our knowledge about this invasive mucormycosis has also increased leaps and bounds after this COVID pandemic. So I'll be talking about management of invasive mucormycosis, and I will be giving you a bit of highlight about the antifungals that are used. And I'll be taking a separate class on individual antifungals, or if you want, on any part of aspergillosis or invasive candidiasis. So we can talk that in a separate class. So just a bit about antifungals, and particularly we're discussing about management of invasive mucormycosis. So start with a case which will highlight the salient points. What are the risk factors that a patient presents to us who can be having a invasive mucormycosis? Then how will you manage them? A bit about the antifungals as I told you and the latest guidelines. So, young 37-year-old female who has a history of increased thirst over the past few days, history of type 2 diabetes mellitus, recent history of wisdom tooth extraction, a history of fever and severe headache for 1 week, and has visible skin trauma with necrotic skin lesions. So, she has got some risk factors, a recent history of tooth extraction, a history of diabetes. So, they can all be a risk factor, and we know that there is a necrotic skin lesion and a visible skin trauma. So when such a patient comes, we suspect some infection. We send all the routine investigations. We also send tissue cultures if we do a sinus biopsy. We also do a CT scan for radiological imaging, and if required, a MRI and biomarkers. So on imaging, we find that a computed tomography scan of paranasal sinuses revealed a significant soft tissue opacification in the left maxillary and ethmoid sinus, indicating sinusitis with potential necrotizing characteristics. So sinusitis with potential necrotizing should always send a tissue culture. So here the tissue culture was sent and it grew rhizopus species, which is a part of genus Mucorales. We did get a MRI scan done, but the patient showed no intracranial image involvement on the MRI, which ruled out any immediate central nervous system complications, which is a very important thing to rule out before doing any surgical intervention. So CT scan as an initial imaging study is usually done because it is quick to be done and it is generally more sensitive for detecting bony erosions. But then when you want to rule out the intracranial, intraorbital and cavernous sinus involvement, it is essential to get a MRI scan done. So that is the relevance of getting a CT scan as well as a MRI scan done in these patients. Pulmonary mucormycosis is also common. So sometimes we have to do, if the patient presents with pulmonology symptoms like hemoptysis, cough, and we suspect a bit of mucormycosis or any pulmonary infection, we sometimes get a CT thorax done. So the most common abnormalities in case of mucormycosis of respiratory system are focal consolidation, masses, pleural effusion, or multiple nodules. Presence of pleural effusion or more than 10 nodules may independently predict mucormycosis, and this helps to differentiate between mucormycosis and aspergillosis in immunocompromised individuals. I'll be talking about two signs in a bit of detail: halo sign, and I'll be showing you images for this. Ground glass attenuation surrounding a nodule. So there's a central nodule, and around this nodule there is ground glass attenuation. So there's a halo kind of around the nodule. And then there's a reverse halo sign in which the ground glass is in the center and there's a ring of consolidation. So again, these are found in mucormycosis. The diagnosis of mucormycosis relies upon the identification of histopathology with culture confirmation. Now, usually culture often yields no growth, and histopathological identification organism with structure typical of mucorales may provide the only evidence. So only a histopathological evidence in a patient who is in an appropriate clinical setting in which he is of high risk, you can think about establishing a diagnosis and treating him as soon as possible with agents against the mucormycosis. So nowadays, fungal biomarkers are being done. So serum tests like 1,3-beta D-glucan assay and the aspergillus lactomannan assay are being used frequently nowadays for invasive fungal infections. But agents of mucormycosis do not share these cell wall components, and neither test is positive in patients with mucormycosis. This can come as a multiple choice question. In our patient, the patient had uncontrolled diabetes mellitus, severe metabolic acidosis and hypertension, and patient had invasive mucormycosis with sinusitis and some bit of cutaneous manifestations. So you know that the patient is of diabetes mellitus and the uncontrolled diabetes is there. So you have to start with insulin therapy. Usually we start with a long acting plus a immediate acting, and we balance out those two and try to maintain a blood glucose level between 140 to 180 milligrams per deciliter in critically ill patients. Since the patient can have a bit of antibacterial infection, we can give meropenem and vancomycin to cover up the bacterial infections. But most importantly, in all the patients usually having rhinocerebral or rhinocerebroorbital mucormycosis, along with antifungals, which I'll be talking in a bit of detail, we have to do a surgical debridement. So usually in our patient also extensive surgical debridement was done. So usually you do one surgical debridement, wait for few days. If you find that you have to do more, you do it again. So a lot of surgical debridement is usually required in patients having extensive rhinocerebral orbital mucormycosis. Then you follow up a patient for a long time. You see the improvement in necrotic skin lesions. Then there should be no signs of invasive fungal sinusitis. Plus the risk factors, like in our case, diabetes mellitus and glycemic control should be taken into account and should be treated well before you can say that the patient is free of fungal infection. So after going through a case, I'll be talking about a fungal infection in a bit of detail. So invasive fungal infections cause substantial morbidity and mortality. And the patient usually has some bit of risk factors. So various risk factors that we know can be hematological malignancies like AML or myelodysplastic syndrome or allogenic hematopoietic stem cell transplantation. Plus nowadays immune modulating drugs in cancer therapy have come up. They present a new spectrum of patients at risk. Plus there are patients with hematologic or oncologic disease without risk of prolonged neutropenia. So we should know what is prolonged neutropenia. So when the patient is having prolonged neutropenia, they are at risk for fungal infections. But when they are not having prolonged neutropenia, they are not at that much risk, so should not get a routine prophylaxis. So prolonged means more than 7 days, and neutropenia means less than 500 cells per microliter. So we should know the definition of prolonged neutropenia. The epidemiology of invasive fungal infection varies upon the host and the environmental factors. And usually we've seen aspergillus and candida cause most of the invasive fungal infections in hematological patients. So most of the studies have been done in these subset of patients. That is why the most of the data is from this. Nowadays, we have moved from spectrum from Candida albicans to Candida non-albicans. So in almost all the critical care settings, initially 2 decades back, Candida was the most common thing. But nowadays,
Okay, I'd found this on the web for initially 2 decades back and elegant.
so over the last 2 decades, what has happened is we moved from Candida albicans to Candida non-albicans. So species like Candida glabrata, Candida krusei, Candida tropicalis, they have become very common in the critical care settings, and they are more dangerous than Candida albicans. And despite improvements in the diagnosis and treatment, invasive fungal infections are associated with a lot of mortality. And that is why, at least in high risk of patients, you will see that in most of the critical care settings, you end up giving an antifungal prophylaxis. But we should be clear which are the subset of patients who are having high risk, which are having not high risk. Now, talking about mucormycosis, mucorales are ubiquitous in nature and can be found in decaying vegetation and in the soil. So they are present all around us. These fungi grow rapidly and release large number of spores that can become airborne. And because the agents of mucormycosis are common in the environment, they are relatively frequent contaminants in the